Thank you so much for that great introduction. Today, I'm going to be talking about SOS, Save Our Skin, for PPE. My disclosures, I am a speaker for Medline Industries, and I'm also a member of the International Consensus Panel for Device-Related Pressure Ulcers. Now, in Canada and the US, we call them injuries, but other parts of the world do not. And this consensus panel had a very large discussion when we first met about how we were going to use the term either injury or ulcers. We agreed that ulcers would be the term for that document. We have another document coming out, and that may be changing. So we're going to talk about a couple things today. I think we all are very familiar with some of the skin issues that have been reported with our PPE over the last year and a half. But I want to talk a little bit about the physiology behind those and also the psychological impacts of the PPE that we've all experienced over the last year and a half. Now, here are some of the things that we've seen. We've seen pressure injuries, MASD, moisture-associated dermatitis, contact dermatitis, maskne, which was never a term until a year and a half ago. And that is the combination of the term mask and acne. But also we have to think about our hands. We have rashes, we are itchy, and we also have to start thinking about some of the respiratory issues that we're facing. Some of these may be related to ethylene oxide sterilization, but we also may be inhaling microplastics. So how common are these adverse reactions that we see? Well, we don't have a lot of issues related in the literature with regard to surgical masks because we've all been using N95s. And actually, it's pretty amazing that we have actually seen up to almost 70% of scarring from our nasal bridge. And we've all dealt with our patients who've had nasal injuries before, but we're having dry skin, we're itching, we have rashes. Our protective clothing is giving us rashes and itches. And our PAPRs are actually different depending on which brand you're using, but we're finding people with facial temperature increases, eye dryness, and so forth. So let's talk about really physiologically what is happening here. This is really a disruption of the skin microbiome. And we all know what the regular skin is like, or it's slightly acidic, although our skin microbiome changes with a lot of different factors. And one of them is gender. Women are a little bit more alkaline than men, and the more mature or older that you get, your skin actually will change its pH, and that's a lot to do with our loss of our sebum. We also know that our normal skin microbiome has bacteria, fungus, viruses, and we also have mites on our skin microbiome. And we have our protective acid mantle, right? But when we actually start adding heat, humidity, and perhaps some other things that like chemicals that we might be putting on our face or our hands, we can disrupt that skin microbiome. And the other nice thing about that skin microbiome, which is kind of adding to that physiology, is once that skin microbiome is disrupted and that skin barrier is disrupted, what happens is that we typically in a normal skin, our T cells are primed to see the bad guys that have come in and try to fight them off because they've been primed from a little earlier microfissures in our skin. But when we have really disrupted our skin microbiome and our skin barrier, then we have a totally different population of bacteria, a lot more fungus, and Candida being probably the most prevalent. And actually the T cells are overwhelmed, which is why we're seeing some of the symptoms we're seeing. So we're really seeing a disruption of the skin microbiome that's causing an inflammatory response. And we also have to think about what is in between our brick and mortars of our our dermis, right? We have the cholesterol, we have ceramides, we have natural moisturizing factors, and which we all are aware of, is that those are the human humectants that actually help keep our barrier in place. So we keep moist inside by these NMFs, and actually we have more at the bottom than we do closer to the top. But once we disrupt that, we actually have an increase in our transepidermal water loss. So every time we use PPE, and remember, before the pandemic, I know you guys had the SARS up there, so you're a little bit more used to it than we are down in the States. But PPE use was not supposed to be prolonged. It was supposed to be short-term, one patient only. But now we were using for a whole shift, and sometimes our shifts were not 8 hours, they were 12 hours. So our normal microbiome actually is changed, and that's because it can be affected by our skin pH, occlusion, humidity, temperature, hydration, our age, our sex. And then what's interesting and very similar to pressure injury is repeated insult exposure. So every time we insult and have shear or friction on our skin, we actually cannot respond as fast to repair our skin. And that's part of the problem we're having. So let's first talk about temperature and microclimate. So I love to use the example of putting your hand into a Ziploc plastic bag, something that you would use for a sandwich or snacks. And if you just put it in there and wait probably about 7 to 10 minutes, you'll actually see that the plastic bag has humidity in it, and almost kind of like your mirror in your bathroom is fogging up. Well, that's because you're starting to sweat. And when you have this increase of temperature, you start to sweat. And then you have the increase of transepidermal water loss plus your sweat. And actually you sweat about 500 to 750 milliliters a day anyway. Now, once you have occlusion there, you will actually start to, the heat and humidity actually changes what is on your skin. So your normal bacteria don't like hot, humid weather. They like things a little bit cooler and drier. So those bacteria that really like hot, humid things start to proliferate. And think about Pseudomonas, and think how we see a lot of Pseudomonas in our wounds because it's warm and moist. When we also have an increase in our temperature, our oxygen requirements are also increased. So both your microclimate changes and your microbiome changes. Okay, humidity. So once it's warm and humid, you actually increase the friction coefficient. So where you would be able to slide things over, now you're starting to actually have a little lag and a little tugging at it. So when you have a moist environment, your cells start to swell, you have an increase in friction coefficient, and then you have a decreased resistance to shear. So this is what happens on our patients too, right? And so we're more apt to have loss of our collagen bonds and stretching of our collagen bonds in the dermal level. So when this happens, especially with occlusion, which is what we have between our mask, our headgear, our gown, our gloves, we actually start an inflammatory response. So it's very similar. We should be thinking about PPE use as a device-related pressure injury. And that's because the PPE alters our skin and supporting structures, and we can't redistribute that applied pressure adequately. And again, as I mentioned before, once we've sensitized the skin to the area, you need less pressure in the same area for a shorter period of time so you're more prone to breakdown as time goes on. So when we think about the PPE really as a device-related pressure injury, think about how these pressure-related injuries occur from these devices. So your device really depends on cell deformation. So if you have a flat device, you're not going to have as a severe or intense injury as if you had, let's say, a pointed device, right? Because you're actually deforming those cells at a greater stretch. And so when you deform the cells actually start to break apart inside, and then they release cytokines within the cell membrane breaks, and then they get released to the surrounding tissue. And when that happens, you start that inflammatory response. These substances actually occlude the vessels along with the direct pressure itself. And then you break your skin barrier, you lose your transepidermal water loss. And then that's compounded by heat and humidity. So friction and shear. So this is your PPE is causing the same thing in you as it is in our patients. So we can't forget what our patients are going through too, because now we're making them use PPE. This is a great picture of a patient in a long-term care setting. So they're allowed to now get out of their room, but they have to wear a mask. So we have seen oxygen tubing cause something similar to this, but this is a new device. So all these things that there are PPE, our patients have not been wearing for prolonged periods of time, they're wearing them too. And this is one is from a surgical mask that was on this patient's ears, and he liked to sit out in the hall, and he sat there for 8 hours and nobody checked his mask. And this is what happened. So we have to remember that our patients wear PPE too. And now we are going to have to start thinking about PPE related injuries in our visitors, especially those that want to sit at the bedside for comfort and prolonged visits. So what's the problem with the PPE for the providers? Well, we know that we're uncomfortable, right? And so we'll try to adjust things when we can, but we're also a lot healthier than our patients. So our tissue tolerance is a lot better. And some may argue with this one, we can control our own skincare regimen. Yeah, we can control what we wash our face with, what we moisturize with. Sometimes we can't really control the amount of time that we want to be on there, because some of the disadvantages, we don't act on some of this discomfort. And this is some of that psychological impact of PPE, is because we, want to not be the one who leaves the unit first or takes everything off first. We really want to be good there for our colleagues. And sometimes we just need to say, gosh, I got to get this off. I need to give my skin a break. So we have to be good colleagues and understand when our colleagues say that. And, these PPE, they're not designed to reduce pressure or cell deformation. They're there to protect us from insults from the outside environment, and they're designed for the short term. None of these things have gone through any testing for biometrics and pressures and cell deformity. So we are really working at a big disadvantage. And we do know that the reason these PPE things work is because they're occlusive. But the bad side is, when you're occlusive, you increase your humidity and your temperature, and you alter your skin microbiome. So let's talk about some of the ways we can improve PPE practices. So let's think about using it as a physiological approach. So instead of saying this is just pressure, we should be thinking we're having an altered microbiome, we're disrupting our skin barrier, and we're getting an inflammatory response. So we don't want to wait until we have the pressure injury. We want to attack this before we're getting that inflammatory response. And one of the things I really want to talk about is that scratch itch response, because that is actually a precursor to pain. So that itch is really from your mast cells are being stimulated, and that's histamine if it's an allergic itch, or substance P, which can be from an inflammatory process. And really it's because your keratinocytes are producing proteases. So what you're seeing here is when you are having heat, humidity, disruption of that skin barrier, what's the first thing that's happening is that you're losing those your natural moisturizing factors. You're losing your ceramides. And so your keratinocytes are going, that's not good. So they're putting out these proteases. And then what they're doing is stimulating those free ending C fibers. So those are really there's pain C fibers and itch C fibers. And so what they're doing is stimulating those C fibers. So the first thing you're starting to feel is itch. So the other thing is, what are we wearing are we getting an inflammatory itch or are we getting an allergic itch? So this is some of the things that we see out here on the market in terms of the types of masks. And you can see they're really have a lot of different materials. So they can be polypropylene, they can be cellulose, they can be polyester, they can be rayon. Some of them have cellulose fiber, some of them have acrylic. And when you look at the mask, you can see the pictures over on the right. These are fibers or materials that are left on the inside of our mask that are microscopic. So when you are breathing them in, we think that you are actually you're responding with an allergic response. Or if your skin barrier is broken, these fibers are actually kind of going into those keratinocyte areas, and your keratinocytes are going, okay, is this allergic or is this inflammatory or is this both? So do I need to get my mast cells going, or do I need to get my C fibers going? So the other thing is that how are they terminally processed? How are they cleaned before they get in the box, before they come to us? So there is some thoughts out there that either formaldehyde or the ethylene oxide may still be have some residual chemicals on these masks, and we may be breathing them too. So are we getting a cough? Do we feel like our lungs are kind of burning or irritated? And if so, is it related to the mask? And there's probably some early data out there saying that we don't know that this may be a problem, but it may be a long-term problem down the road that we will find that it has been a problem. So it's interesting to find out where your masks are from, and you may not be able to find out where or how it was terminally sterilized, but if you're starting to feel a little bit rashy or hoarse or just uncomfortable in the upper throat, it may be either one of the fibers or how it was sterilized. So just change your brand and it may be helpful. So what we want to know is know the in before putting on. So I like to think about everything that we put on our patient's skin. We know the ingredients on, but we should be looking about what ingredients we're putting on ourselves. So the in is ingredients and instructions and contraindications. So look at the in before you're putting on. So what's the pH? So when we cleanse our skin, we should be looking obviously at a low pH, just like we would cleanse our patient's skin. But remember, if we have a high pH, you're going to activate those skin proteases and you're going to cause an itch. And so we should be looking at our what we wash our face with and what we wash our hands with. So the question is, half the time we don't know what our pH is. And there is a website out there called skincaredupes.com. And they have looked at several hundred different types of over-the-counter cleansers and have looked at the pH. So take a look at that, because maybe some of the issues that you're seeing on your face or your colleague's face, or maybe even some of your family, is maybe related to the pH of their cleanser. And here's a sample listing of those pHs. So I think we always say, oh, use Neutrogena because it's slightly acidic. But look at Ivory soap and Irish Spring soap. It is actually uh, acidic and not alkaline. So we really want something closer to our own pH. So our barrier cream, sprays, wipes, we've seen these in the guidelines to put this on our face to prevent our stratum corneum from getting excessive moisture from the humidity, from the occlusion that's essentially raining on our face. So they actually don't provide a whole bunch of hydration to our skin. And we have to remember that. So if you're dry to start with, you're not going to get anything more when you put one of the sprays on, or the wipes, the barrier wipes. So if we want to moisturize, we're really thinking about creams. And so a lot of creams, they are really heavy metal in an oil water emulsion, and that's very traditional. So you really should be starting to think about silicone based. We use them for our patients. They work great for our patients. We should be thinking about using it on us a little bit more often. We have a tendency to put a whole bunch on because we feel so dry, but you just have to use it very, very sparingly, and so you don't have any residue at all. The advantage here is that when you use a silicone-based cream, you actually have less adhesion problems with dressings. Now, the sprays, the advantages to the sprays and wipes would be that, it's not going to impact your fit test. And we do see the use of cyanoacrylates. And so far, we haven't seen any bad things reported from the cyanoacrylates, which is a good thing because they really do a really nice job in terms of keeping your stratum corneum from getting rid of excessive moisture. There is a little bit of transepidermal moisture loss, but it's normal, which is why it works so well in our patients with incontinence-associated dermatitis. So have anybody looked at the ingredients in barrier wipes? So this is your typical barrier wipe, and isopropyl alcohol, like would that be drying? Water, SD, ethanol 40, and then all these other things that will actually sting. So, and probably not be very helpful in terms of keeping your skin healthy. So, which is why you probably, if you're going to use a barrier wipe or spray, moisturize well to get into that stratum corneum with a ceramide and fill in that lipid layer well. And then what you want to do is use that cyanoacrylate to seal things over. So what's in our cleansers and moisturizers? Well, we want humectants, right? We want to get into the dermis and epidermis and increase that water content. And all of these are humectants. And the ones that actually work really, really well are the ones in bold. So we have used ammonium lactate. We use it for stasis dermatitis. We use glycerin, hyaluronic acid, urea, sorbitol. So we're pretty familiar with these, but these are the ingredients where you really want to concentrate on finding. So if you're going to put it on your face, you have it. So what other things are in there? So you really are going to want to look for ceramides, because again, you're going to lose ceramides when you have lost your transepidermal barrier, and they're going to leave. So you have to fill in that mortar again. So ceramides are great for doing that. And so you have to think about what you see. And again, the ones that are in bold are ones that are people try to sell you as, you're not going to ever get a wrinkle ever again. And the reason that a lot of those work is because they react with free radicals. But the question is how deep do they go into your dermis? And they usually don't go that deep. So they may make you plump and look a little bit better for a little bit, but in the long term, they don't really help you unless you're using a very, very strong formulation, such as a real strong formulation of retinol. EDTA, which is actually a preservative used in a lot of wound cleansers and skin cleansers actually can enhance the other antioxidants. So it will help you help your face. So when you're looking at capsaicin, so that's also in some of our cleaners and moisturizers. And what's that do? That actually kind of soothes those C fibers, so you don't itch as much. So that's how that works. Okay. So emollients are those ingredients that remain just in that stratum corneum, and they're just really kind of what I call the mouthfeel of skincare, right? So they really aren't helpful in terms of improving the skin health, but boy, they feel really, really good, and they can hydrate if you have the right amount of lipids in emulsion. They do reduce your skin's ability to have transepidermal water loss, but they're not really occlusive, but they feel really, really great. And here are some of the things that we see in our ingredients in our skincare products that are emollients. And then those are occlusive moisturizing. We have a tendency to want to use these under our masks because we feel that it's going to have a really, really good barrier, such as, the mineral oil, plain old petrolatum. But dimethicone is actually probably one of the best things for you, again, because it has this hydrophobic barrier. So it's going to reduce that humidity and humidity on your skin itself. The problem with the many of those occlusive moisturizers is they're greasy. Not all the dimethicones and the silicones are greasy, so I would probably steer you towards that direction. Again, as we tell our patients, put it on when your skin is still damp. And think about all the other things that we have. We have surfactants, preservatives, stabilizers, detergents, gelling agents, and we have alcohols. So look at the label. It's really, really telling before you start using it on your skin. And if you're starting to have a problem, it may be because you have a high alcohol content in your either cleanser or moisturizer. And of course, those allergens. So these are some of the more frequent allergens that people turn up to. Now, I have to say, somebody's going to be allergic to something along the line. So all these things have been, when these skin products have been out, they've been tested. They've been tested against animals, sometimes against humans. But you can develop a sensitization over time. So one of the big things that you might be seeing is maybe your rash is because you are starting to get sensitive to parabens. Nickel is very, very frequent. Fragrance, which we know we want to avoid, but we can't sometimes because we all want to smell nice, right? Neomycin, balsam of Peru, gold, and any of the quants. And some of the quants, including quant 15, is a cleanser. So we're seeing that a lot. So these can be contributing to your maskne or your inflammatory response. Don't forget your lips. We always forget our lips. Our lips get dry, they get cracked. And we need to put on ceramides because that is the most important thing. Fill in those gaps. So when we talk about PPE and the role of dressings, so foam actually is the most likely to control the humidity and temperature and moisture, but the devil's always in the details, right? Because all these foams are constructed very differently. The foam size, the pore size can be different. Some of them are hydrophobic, some of them are hydrophilic. And then are they silicone? Or are they polyurethane? Are they a combination of both? And then the question really is what is the impact of the material when you cut it? So we have great dressing data on the actual foam itself as it has come from the package for our patients, right? But what have we done when under PPE, we're cutting, we're pasting, we're putting things every different way. We don't know how that's impacted the ability of the skin or of the dressing to redistribute pressure. So one of the things that I know that Emmet Geffen's lab is doing, he is out of Tel Aviv. He is a biomechanical engineer, and he can actually test some of these dressings under PPE, and we're in the process of doing that now. And again, as I talked about before, if you cut it, we've talked about the fibers before, but if you cut it, now are you increasing the ability of your foam to maybe give you more fibers or more material, either inhaling it or irritating your skin? What about our psyche? Well, you know what? A lot of times we'll be over a bedside and we'll just give somebody the old eye, right? And so we do communicate with our eyes, but sometimes we communicate a lot with our smile or a frown or, a little, So that's a problem because our colleagues can't read each other when we only see this piece. And so our vision can be impaired, especially if you're like me and have to wear glasses because you're fogged up all the time. We become socially isolated. We can't hear our colleagues. We misinterpret them. Our patients certainly can't hear us. We end up getting headaches. And there may be some relationship between the use of PPE and headaches in terms of vascular occlusion, which is really interesting. There's some early data coming out about that. We do have some data about PPE and its prolonged use causing us to reduce our work performance and increase our resistance to breathing. There was a great study where people had PPE, the N95s, and they just had to climb a flight of stairs. And you know what? Their oxygen saturation dropped. When they weren't wearing the mask, they didn't drop. So it does increase the work of breathing. And I think that's making us tired, perhaps a little oxygen deprived, which may also be contributing to headache. And of course, our altered body image. I mean, we all look really terrible in PPE. So it's not very appealing to our patients and sometimes not to our colleagues either, that we just don't look as smart as we used to because we're wearing things that don't fit us very well. So, and frankly, to be honest with you, I'm a fuchsia girl, right? I need fuchsia. And I look great when I wear pink. And if I'm wearing, those horrible yellow things, I look pale and washed out. So if I were to start a business, I would make those PPE gowns a lot more colorful and with a lot of designs. Okay. So again, we know that when we pull, if we're anxious, and I think we're seeing less of this because now we know more about the COVID-19 phenomenon, is that we're not as anxious. I don't think we're pulling our PPE as tight as we did when we first started a year and a half ago. But again, what we end up seeing is we don't want to blink. We don't want to be the first one to get everything out of our PPE. So our PPE, I say, impacts our pee time because we don't drink while we're on because it takes too much effort to get everything off and get everything back on again. We get dehydrated, which actually leads to decreased tissue tolerance and of course a pressure injury. So it's a vicious cycle. So we have to start really taking care of ourselves a little better. It's hard. It's really, really hard. But I think we need to encourage all of us to do so. So when you treat the physical, we'll also treat up here. So, itch is a symptom and the cause we don't know. And if we see a rash, is it a symptom or is it a response to inflammation? So how do you respond to itch? So again, as I talked about this, is it inflammatory or allergic? And look for the locations. So this person has severe eczema, a mask, and you're going to see it. And that's really a lot of it was, and there's some yeast involved, and there's really a lot of candida here. We had some cheeks, nasolabial folds, lips, scalp, skin folds. And of course, because we're sweating and our apocrine glands are actually different in our perineal area and our axial area, they're more alkaline anyway to start with. And then we add that heat and humidity, we actually get candida and other fungal rashes in places that aren't directly exposed to the PPE, but are feeling the results of it. So if, we have meds to treat the allergic reaction, and we've all used topical steroids in our practice. Just remember that fingertip rule. You should never put more than one crease of your fingertip to the top, and because then you're going to actually cause more problems with excess steroids. We do see the topical calcineurin inhibitors used on people with severe problems with their PPE on their face, and it is okay for that. And then Pramoxine 1% is okay as a topical anesthetic for pain. You can use antihistamines. You probably don't want to use them before work because they're really sedating. And depending on what drugs you're using, it can, which histamine receptor site you're impacting, you can have drug-to-drug interactions. You also can use for itch anticonvulsants, antidepressants, and of course oral steroids. I don't think any of us want to take anticonvulsants or antidepressants for itch for a number of reasons. We really want to try other things first. Oral steroids would be the first thing we'd want to try if we aren't doing well with a topical agent. So coolants, boy, they feel really good, and we've all used these on our patients. So think about the menthol, the camphor, the phenol. And what they do is they work on the thermosensitive nerve endings. But if, again, look on the label, if it's greater than 3%, you're more apt to get a skin irritation. So crisaborole is a 2% ointment, and that actually is very, very soothing. And you can use any of these in children older than 2 years. And you can also use it in very sensitive areas of your own body, including the anogenital and intertriginous areas, but they may sting. So again, to improve your practices, know what you're putting on your skin, think everything as a physiological issue rather than a response. So if you can think physiologically, you'll solve the problem. So care for yourself. It's really, really important, and care for your colleagues, because if your colleagues aren't there or impaired, that actually will increase your workload too. But we're nurses, and we like the people that we work with, and we want to care for them too. But there are tons of opportunities for WOC nurses, right? Because this is a whole new area that none of us have really experienced before. So we have to look for those gaps in that research. And if we have that opportunity, is participate in research. I see the things that have come out of Canada. You guys are way ahead of us in terms of doing research and looking at this. Also, I think this is a great time to look at new work processes and find out the best work processes for us, for our skin. And also, nurses are great innovators. We have invented a lot of things that have gone to market and have benefited our patients. And now's the time to start thinking about what works for us under PPE. And then we should be able to approach people, manufacturers, and come up with new products to help us and the entire world. So with that, I want to thank you so much, and I'm willing to take questions.